So we're going to start with our first presenter, and I'm going to introduce to you Dr. Kiran Pienaar. She's going to be making a presentation of understanding intersections between gender and health. And I'll tell you about her in a bit. Dr. Kiran Pienaar is a senior lecturer in sociology at Deakin University, Melbourne, Australia, and she's also an adjunct senior research fellow at the Australian Research Centre in Sex, Health and Society, La Trobe University, and an honorary research associate in Rhodes University, South Africa. She has expertise in gender, sexuality and drugs with a focus on narco-feminisms, those tough names, LGBTQ identities, social dimensions of health, and she's published topics on addiction, queer drug use, very unique topics, trauma-informed care, COVID-19, HIV epidemics, and her publications include co-edited collection of narco-feminisms, revolutionizing drug use, and a monograph titled Topics on Politics in the Making of HIV in South Africa. Please, let's put our hands together and welcome Dr. Pienaar for her incredible work.
Thank you so much for that warm welcome and the introduction, and special thanks to INHSU for their generous invitation to present today. It is such an honor to present off the back of the Jude Byrne recipients. Congratulations to you all, and thank you for the inspiring work you do. Today I'll be presenting on the intersections between gender and health, and I'll draw on some of the narco-feminist activist work that we mentioned shortly. I will give you an introduction to that, but I'm sure many of you in this room, whether you identify as narco-feminists or not, will be familiar with the kinds of principles and the philosophy underpinning narco-feminist activism. I'm also especially delighted as a South African that the conference is being hosted in South Africa, my home country, my heart country, and for the first time on the African continent. I want to start with an acknowledgement of country, which is an important part of Australia's recognition of the traditional owners of the lands and acknowledgement that sovereignty over these lands was never ceded. And this acknowledgement is not intended to be merely performative, but rather to give us pause to reflect on belonging and place, especially in post-colonial and settler colonial contexts. And this seems especially important in light of ongoing conflicts over land in the Middle East and elsewhere. So with this in mind, I respectfully acknowledge the Wadwurrung, Wurundjeri, and Boonwurrung peoples of the Kulin Nation and the Gunditjmara people, who are the traditional custodians of the unceded lands and waters on which my institution, Deakin University in Melbourne, is based. I acknowledge the traditional owners' enduring connection to country, always was, always will be Aboriginal land, and I pay respects to elders past and present. And sorry, I'm old school, so I have my notes, even though I can see them up on the slides, thanks to the amazing tech support here. Oops. Okay. I also want to acknowledge that this presentation is based on an edited collection titled Narco-Feminisms Revisioning Drug Use, and it is inspired by the narco-feminist activist movement, which I'll shortly introduce. I'd like to acknowledge my co-authors and co-editors on this work, Faye Dennis and Marcia Rosengarten, and the cover of the book is featured on this slide. But most importantly, I'd like to thank the narco-feminist activists whose work inspired this collection for their tireless advocacy. And I've included here details of an interview that we did with some narco-feminists, which includes some really great insights on the movement and their advocacy. And if you'd like to access any of the material, I'm very happy to share the slides, and most of the work is published open access. Special thanks too to narco-feminist artist Jamie Harare, whose beautiful images feature throughout this presentation. And I'm really delighted to have the opportunity to share this work with you. It was a really generative collaboration, and I hope that you'll find it interesting and relevant to some of the discussions today. So just to give you a sense of what I'll cover in this presentation, and I know I only have 20 minutes, so it'll be a rapid whistle-stop tour. I'll be discussing the gendered nature of risks faced by women and gender diverse people who consume drugs, a topic that I know is familiar to many, if not all of you in this room, including stigma and discrimination, sexual health and pregnancy, and gendered violence. And I'll introduce the narco-feminist movement and draw on insights and inspiration from that movement and from drug user advocacy to discuss how we might design HIV, viral hepatitis, and harm reduction services for women and gender diverse people who use drugs. And in closing, I'll give some examples of gender-sensitive, trauma-informed care. I just want to give a quick note on terminology. As I was preparing these slides, I thought it's important to discuss who's included under the umbrella of women and gender diverse people. You'll see on this slide I've used the term woman with an X as a gender inclusive term to include non-binary, transgender, and gender diverse people. But of course, language can be contentious, and I know there's some people who for various reasons prefer not to use this term. So I've tried to include a range of terms in the presentation in the spirit of inclusivity. So let's start by looking at some of the issues that face women and gender diverse people who use drugs. As I'm sure you will be very well aware, this population faces significant gender, social, and economic inequalities, including increased rates of violence, housing precarity, homelessness, and increased overdose risk. And yet their gender-specific needs are largely overlooked in health and drug services. They often have limited access to drug treatment, sexual and reproductive services, and antenatal care. And I was really struck yesterday in some of the presentations by the comparatively low rates of women accessing services, drug services in different settings compared to men. So I think, although of course there's incredible work being done to transform services and to ensure that they are gender sensitive, there is still more work to be done. Relatedly, those experiencing gendered violence, including transphobia, often face barriers in accessing harm reduction and treatment, including controlling behaviours from partners that prevent them from seeking health care, harm reduction or treatment. Women and gender minorities are a priority population for HIV and viral hepatitis prevention, but their gender-specific needs are often overlooked in this context too. They are also, and you will be familiar with this, subject to stigmatizing stereotypes such as the bad mother, and I won't give any more oxygen to any of the other awful stereotypes. But women and gender diverse people who use drugs are perceived as more deviant and pathological than their male counterparts. They're seen as more out of control, sexually promiscuous, more irresponsible. And they are subject to gendered, classed, and racialized forms of regulation, such as the violation of their reproductive rights via forced abortion, sterilization, and the removal of their children from their care. And as Diego mentioned yesterday in the policy reform session, in the context of Latin America, and it applies in other contexts too, as we've heard, women who use drugs also face higher rates of incarceration. So in short, women and gender diverse people who use drugs are subject to a multiple whammy of stigma that infringes on their rights and renders them especially vulnerable. And I think this quote by Judy Chang, who needs no introduction in this room, former executive director of Input, powerfully highlights these issues. As Judy writes, due to criminalization, punitive policies, and stigma and discrimination, women who use drugs are 2 to 5 times more likely to experience gender-based violence and intimate partner violence compared with women who don't use drugs. Our sexual and reproductive health rights are suspended. We are at times subject to forced abortion and sterilization, routinely denied child custody rights, turned away from health services, and treated as second-class citizens. In many parts of the world, women who use drugs are more likely than men to be incarcerated for the same offense or face harsher sentencing laws. With all of this in mind, it is troubling that empathetic links of solidarity have not been extended by many mainstream feminists to women who use drugs. And in response to this exclusion from mainstream feminist agendas, a group of feminist drug activists from Eastern Europe and Central Asia formed the narco-feminist movement. Narco-feminism, for those who might not be familiar with it, combines a feminist and human rights agenda to push for more humane drug policy, for harm reduction and decriminalization. It champions the right to use drugs, as we've heard some of our Jude Byrne recipients say, to live in safety and freedom, and to reclaim bodily sovereignty. And the movement has now been taken up in harm reduction, drug policy, and drug user advocacy worldwide. And there is a session in this conference which introduces and discusses narco-feminism, and I think this is testament to its global reach. So with all of this in mind and drawing on insights from the narco-feminist movement, and I really want to emphasize this talk comes out of drug user advocacy. This is grassroots organization that so many of you in this room are involved with. I ask, drawing on these insights, how could things be different? How might we design services for women and gender minorities? As I mentioned, harm reduction interventions are typically gender neutral, which means they fail to address the systemic and everyday racialized, gendered discrimination, stigma, and violence that can extend into service settings and limit women's access. For example, few opioid agonist treatment programs have been specifically designed to support women who are pregnant and/or parents. Despite the significant proportion of women on OAT who have children and the identification of pregnancy as a motivation for seeking treatment. This highlights the need for gender-sensitive, trauma-informed care. And there is a growing acknowledgement within the alcohol and other drug sector and within health policy and practice that measures designed to support people can themselves be trauma-inducing or re-traumatizing. They often obscure the structural violence and the punitive systems embedded in our institutional systems. So there is a need to transform organizational cultures and practices to avoid reproducing systemic trauma. And so I think drawing on narco-feminism and drug user advocacy, trauma-informed approaches really need to reckon with these structural dimensions and offer gender-sensitive, strengths-based interventions. Interventions that acknowledge clients' agency in managing trauma and that center the knowledge of those with lived and living experience. And I know that's kind of a clarion call that we've heard throughout this conference, the value of centering the voices of those with lived experience. Another recommendation is to offer no barrier access to harm reduction supplies, such as safe injecting equipment, for example, not making stable housing or treatment a condition of access. Related to this, a need to center the values of safety, trust, collaboration, and peer support. And finally, it's vital that services are adapted to the needs of clients. And here again, I want to acknowledge the drug user advocacy that has paved the way for these kinds of interventions. And we'll hear examples, and we have heard examples, of innovative approaches that are led by community organizations, drug user advocacy groups. Activists and those with lived and living experience have worked really hard and continue to work tirelessly to challenge the assumption that any illicit drug use, regardless of frequency and patterns of use, is a problem. If we move beyond risk-centered problem framings, people might be enabled and resources allocated to live with drugs in positive ways. But if this is going to be achieved, then researchers, policymakers, and service providers need to collaborate with affected communities, particularly advocates and activists who are already involved in this work, including so many of you in the room here. In short, more training and research is needed that is informed by the harm reduction movement in order to challenge stigma and promote diverse understandings of experiences of drug use. And of course, this is especially important in the current moment with the US funding cuts, which have led to reduced drug services in so many countries relying on US funding. And as we've heard in the conference, these funding cuts have increased the vulnerability of people who use drugs, and without adequate support, they face greater risks of HIV infection and other health issues. And there is a session, I think, later today that looks at the impact of the funding cuts and how we can respond to those in innovative ways. So given that I've painted a rather grim picture, I wanted to close with some positive and inspiring examples of services that already offer these kinds of trauma-informed, gender-sensitive interventions. And I'm sure delegates in this room can share other inspiring examples. One such example is Sister Space. It's a woman-only overdose prevention site or safe injecting centre in Vancouver's downtown east side. It opened in May 2017 and is an inclusive space. So it's open to trans women, genderqueer women, and non-binary people. And I've included a link in the slide to the service for those who are interested to find out more. It is non-institutional and it offers clients a temporary reprieve from some forms of stigma and discrimination. And here is a quote from a client that I think really describes the sense of safety and care that Sister Space offers. "It's a really, really good environment," she says. "I feel comfortable, I feel safe. I eat a lot." You know what I mean? Like the peer staff, seem like they're little hostesses and they're just like, "May I get you something?" And they're very kind and loving and compassionate. I love it there. And here Brenda emphasizes the value of peer workers' care and empathy and the sense of inclusivity it fosters. This is so significant given the pervasive stigma and discrimination faced by women and gender minorities who use drugs, particularly when they seek health care. Another example closer to home comes from Kenya, two coastal towns in Kenya, Mombasa and Kilifi, where community-based outreach services integrated sexual health care with HIV and harm reduction services. These centers target women who inject drugs, and stakeholders highlight how the sexual needs of women who use drugs is a neglected issue in drug services in Kenya. One outreach worker explains, "The issue of reproductive health has been a challenge. The level of women's access to these services is very low. But you know, people who use drugs have been neglected for long. It has now become a big issue. Women should be a priority in this. We need programs addressing issues of women who inject drugs." And the study I've quoted here, I've included the details on the slide, found that this gender-sensitive integrated model of care attracted women to harm reduction services. As she explains, "I've seen change as an outreach worker. I've seen clients accessing the service improve in terms of their interest in needles and syringes because of the sexual and reproductive element." In preparing for this presentation, the organizing committee asked me to provide some takeaway messages for the conference newsletter, and I thought it was a really great idea. One of their prompts was, what are some insights or ideas that you'd like people to carry or take away from this session? So here are a few reflections that struck me, and I hope they resonate with you. I think they'll be very, very familiar to all of you in the room. Many of the harms that are routinely attributed to drugs, we know are actually the products of prohibitionist drug policy and punitive approaches. And these harms disproportionately impact women and gender diverse people who use drugs. Addressing them requires policy and legal reforms, which many of you in this room are leading through your advocacy and policy reform efforts. That will also require gender-sensitive, trauma-informed care. And it will require policy shifts to recognize, as people have already said, the rights of people who use drugs, and importantly, the intersectionality of oppression. In other words, the ways in which people's experiences are shaped by gender, sexuality, race, class, and disability. Narcofeminism and drug user advocacy, and we see examples of this at this conference, offer very valuable examples of rights-based social justice approaches that can guide policy and practice. In closing, I want to give the last word to one of the narco-feminists we interviewed for the book that I mentioned earlier, and her name is Ala Besanova. She captures the inclusive spirit of the narco-feminist movement. As she says, "What attracted me to narco-feminism is its appeal to intersectionality. It allowed me to accept all different kinds of women in their diversity. I have experienced organizations of sex workers who don't accept women who use drugs, organizations of women who use drugs or communities who won't accept sex workers, or LGBTQ communities who will not accept a lesbian who uses drugs. And for me, narco-feminism was this island that accepts all women, and this really empowers and motivates me. I think Alla's words are a call to action for more inclusive, gender-sensitive forms of care and solidarity in the drug sector. And I want to acknowledge and thank those of you, so many of you in this room, for your tireless advocacy in this regard. Thank you very much. I've included...
Thank you so much, Dr. Pienaar, for that fantastic talk. If I could ask you to please stay on the stage for the next speaker. I'm sure we have a lot of questions and things to discuss. There will be a discussion section after the two speakers. Please put your questions in the Q&A chat if you'd like. We'll also have take questions in the room.